careful or cautious when we giving them to patients who have kidney issues. So CKD incidence in elderly patients is higher by 8%. So this is also an issue, because if aging is a reason or a risk factor for developing CKD. So the most important part that you need to understand here is the pharmacokinetic of drugs in renal impairment. So how do they actually work? So the journey of the drugs are taken in either IV, IP, orally, and then they have to be enter the circulation, taken up by tissues, and then secreted either in urine, metabolized into different forms, or secreted, or taken in by other secretory fluids. So that's the journey of the drug. So how the pharmacokinetic of the drug actually works in renal impairment patients. So the first thing is that you need to understand the four principles of pharmacokinetics: the absorption of the drug, distribution, metabolism, and elimination. So what happens in each of these compartments during in a renal patient So absorption is dictated mainly by the bioavailability of the drug. So to understand all these compartments, you need to understand the bioavailability of the drug. So for example, furosemide, if it's given IV, it has 100% availability in the circulation. But if it's given orally, only 50% of it is available in the circulation. So this can limit the absorption of how much drug is actually available. So in renal patients, uremia can cause nausea, vomiting, and diarrhea. So this can be a factor to reduce absorption of the drug. If the patients are using drugs that such as aluminium or calcium phosphate binders with other drugs such as antibiotics or iron supplements, this can reduce the absorption of the drug, and because of the reduced gut motility. Another example is if the patients are taking gastric pH, drugs that increase the gastric pH, like ranitidine, for example, they can be affected, they can impair absorption. So you need to be wary of these kinds of drugs. Distribution. So when it comes to distribution, you need to understand that when the drug enters the circulation, it's found in two different forms. Either bind to proteins or active or available freely active in the system. So in patients who have renal impairment, they usually have a reduced protein binding. So that means more free drugs are available in the system. And this can cause adverse drug reaction. And also because uremia in those patients, in renal patients, can cause or increase the blood-brain barrier permeability. So that means these free drugs can enter the blood-brain and cause neurotoxicity. However, when it comes to this, you need to understand there is the volume of distribution. So the volume of distribution is a formula that we use to calculate how much of the drug should be available in the system to prevent adverse drug reaction. And the volume distribution is usually affected by things like edema, for example. So if the patient has edema, that means has increased fluids in the body. So in that case, increased volume means that we need to increase the dose. That's the only time where it has to be careful. Another example, or actually what happens in metabolism, the next stage is the slower, that's in CKD, metabolism is quite slow. So this can lead to increased adverse drug reaction. Vitamin D, also, do you know how vitamin D is produced, or what's the enzyme responsible?
125.
The enzyme. So the kidney makes the vitamin D, so what's the enzyme that converts? 1-alpha hydroxylase.
Yes.
So the enzyme converts the inactive form of vitamin D to the active form, which is 125 hydroxy.
Dihydroxycholecalciferol.
Sorry?
Dihydroxycholecalciferol?
Yes.
Yeah. So that's the active form. So, but in these patients, because they have renal function, their renal is impaired, then we have to give them the active form of vitamin D. Insulin is also reduced because insulin can cause, insulin absorption is reduced in renal patients. So that means the patients can develop hypoglycemia. And thus we need to reduce the dose to prevent hypoglycemia on those patients. If they have renal failure as well as diabetes. So elimination in general is reduced in renal patients. So accumulation of drugs active metabolites is highly likely, and this will increase the adverse drug reaction like toxicity, like phenethylene, because it has a narrow therapeutic index. So how would you determine the dose that should be given to the patient? By looking at which of these parameters?
Wait.
All of them.
Serum creatinine, serum.
GFR?
We have to choose one or more?
Yeah, okay. Blue 2.
Two?
Yeah.
Creatinine.
Urea and GFR.
GFR is the same as creatinine. Aren't they the same thing?
But they're not accurate. It's because they use a formula. So creatine clearance and EGFR is the most commonly used ones. So the estimated GFR is basically the volume of blood filtered at the glomerular each minute. Usual lab reports, they look at the estimated GFR to the normalized body surface of 1.73. So these are calculations. But you have to take care in terms of extreme body weights or amputees or people who are obese. So these could be different. Well, I mentioned the BNF. Okay, so usually people refer to the BNF to get an. Do you have a question? Sorry. So BNF usually is used for most drugs. So to get like the dose that we should give to these patients. But it's usually only available for patients with average build and height. So this doesn't include children, amputees, obese patients, and elderly. So we have to take care, or even toxic drugs, they're not part of it. So GFR is
BNF. What's BNF?
You don't use the BNF? Okay, it's the British National Formula.
Okay.
So it's the booklet where it has all the drugs and they use it. So what do you guys use?
We're still in the study.
Oh,
We will take it maybe later.
okay, so therefore forget it. But usually BNF is used worldwide. But okay, don't forget about it. But what I'm trying to say here basically is usually the doses are given in general for patients who have average build and one weight. But the exception of the use for EGFR is if they're elderly patients, if they're extreme body weights, or if the drugs are toxic, like drugs with a very narrow therapeutic index. In that case, the EGFR cannot be used to determine the dose that we need to give to patients who have renal impairment. So, but we don't adjust the dose unless the EGFR is less than 60 ml per minute. So this is the first formula. The second formula is the creatinine clearance, which we use the Cockcroft and Gault equation. So this is the formula. Usually for males and females, we use different numbers. We use the IBW for men 50K. That's the average women about 45. But you don't have to memorize those calculations because they're available online. So, but the disadvantages of the Cockcroft, similar to EGFR, is not useful for children, obese or underweight, pregnant women, or ethnic minority. So basically, because these kind of formulas were mainly meant or prepared for an average white Caucasian male. So the creatinine clearance versus the EGFR formula is that there is no compelling evidence to suggest that there is any superiority of any of these methods. So they can be used, or any of them can be used to calculate the dosing adjustment in renal diseases. But in most cases, people can use any of them interchangeably. However, you need to be careful because sometimes in some clinical trials, they would calculate the dose based on for example, the creatinine clearance for metoprolol. So we have to follow that. So if there's guidance already available, we have to follow those guidance. Otherwise, the pharmacist can choose any of these. But we have to be careful to interpret these, how these equations work. As I said, for amputees, muscle wasting, if there's fluid overload, if there's dehydration or high dietary intake of meat. So in that case, usually the clinical judgment is there as well as caution is taken. And as I said, the EGFR cannot be used for toxic drugs, elderly patients, and patients of extreme weight. In that case, we prefer to use the creatinine clearance formula. So what are the approaches that we use in renal impairment? So here, what you need to understand is if we're giving the drug only one dose, we don't have to do any dosing adjustment. But this is usually more important if the drug is given over a long period, so maintenance dose as we call it. So in that case, if the patient has renal impairment, then we have to follow one of these options. The first one is that we can give the same dose, reduced dose, but at the usual interval, at the same as patients who don't have any renal impairment. But that's one example. Another one is the drugs that can be given at the same dose as normal patients, but at extended period. So instead of giving co-amixiclav every 8 hours for these patients, we give exactly the same dose, but at every 12 hours. But it's usually better to give alternative drugs when we can. So if we know there's a drug that works better for these patients, it's better to give them. Like especially with morphine, because it's a nephrotoxic drug, we tend not to give it, so we try to give oxycodone. So you don't have to know about the venlafaxine, apixaban. These are just examples, but what you need to know about is these 3 different approaches that we use to endorse regimen in renal patients. So overall, what we do is usually something called a stepwise approach to dosing adjustment. So in general, to cover what I've just mentioned, is that first, when we have a patient who have CKD or we think he's a risk of CKD or taking drugs that can induce a CKD or acute kidney injuries, we have to look at the history, physical examination, calculate the IBW, review the medication list, see if there's any prior drug tolerance. Then we calculate the EGFR or creatinine clearance. Then we try to determine the loading dose. For normal, which usually the normal, the normal is the same for the normal renal function. But if it's a maintenance dose, then we have to look at giving at varying intervals or extending or reducing the dose. Finally, we have to monitor. So when we do that, we don't stop there, but we have to monitor what actually happens. Do we have to use a different approach, or shall we stick with this if we don't see any adverse effects? Okay, so I have this clinical example. You can read it and tell me what's going on.
Miss RT79 presents with confusion. UNE, LFTs, FBC, TFT are normal. CR 160 micromole per liter has slowly rising over the past 10 years. EGFR is 29. Has taken digoxin 25 micrograms daily for AF. 250 micrograms daily for AF for the past 10 years. Digoxin level 3.8 micrograms per liter. Can you explain what is going on?
Stage 4.
Why do you think it's stage 4?
The EGFR, the range is 29 to 15.
Okay.
Shouldn't we have
Just
EGFR 10 years ago before they started the drug?
No, but you look at the clue. So what did it say? It says Mrs. RT, 79. And it says that the creatinine has been slowly increasing over the past. So it's not like she was given the drug and they forgot about her. So she's been monitored and they've seen there's an increase. So there is a risk of aging here. But what is it? What do you think is actually happening? Why all of a sudden she came to the hospital with confusion?
Hyperkalemia.
Renal failure.
Uremia.
So digoxin is not excreted.
Yeah, basically. So digoxin is causing acute kidney failure.
Yeah.
And the dose is too high for her. So what would you do?
Lower the dose.
No, stop the medication.
This is over time. I would give it over a longer frequency.
Alternative drug.
Alternative drug.
What's alternative drug would you give?
Steroid.
Yeah, but usually with AEF, like she got arterial fibrillation, we try not to take patients from digoxin. Say we did, maybe we can give her Bexaban for some time or another drug, but then we have to put her back. But reduce the dose because because this is an acute kidney failure, or I can't say it's acute kidney failure, but there is a damage caused. It's a drug-induced acute kidney failure due to digoxin. So in that case, what we do is reduce the dose. That's the best approach we go for. Okay, so acute kidney injury is defined by rapid deterioration in renal function over a period of time, over a few hours. And usually is seen in 20% of patients admitted to hospital with high mortality rate. And AKI usually is usually drug related most of the time. But incomplete recovery can lead to worsening or new effects of chronic kidney diseases. So it's the most common cause of leading to chronic kidney disease. There are many risk factors involved. There could be pre-existing chronic kidney disease, heart failure, liver disease, diabetes, history of AKI. Most commonly, I would focus on it like the use of the medicines that impair, so OTC, like NSAID drugs. Sepsis, being over the age of 65, so aging is an issue, is a predisposed factor. So the acute kidney, when we have acute kidney injury, the first thing we do when we see a patient coming to the hospital, usually they suffer from diarrhea or vomiting. We stop the drugs if they are taking any drugs that we think they are exacerbating their effects or they are unsafe to use. So an example of that is NSAID. Do you know an example of NSAID?
That could be safe.
No, what's like NSAID is a drug class. Can you give me an example?
Aspirin, ibuprofen.
Yeah, so naproxen, these kind of drugs. So ACE inhibitors,
Captopril, Napril.
angiotensin 2.
Erixi something.
Okay, metformin is given for diabetic patients. So that metformin is the most common drug that can actually cause no lactic acidosis. So we try to, in patients who have kidney disease, we try to reduce the dose for them, or stop metformin, but we try not to, or give them insulin sometimes, put them in insulin. There's also contrast media that used for CT scans or X-rays. Some analgesics, DMARDs like methotrexate as well. So doses may need changing according to degree of renal impairment. So dose adjustment usually require monitoring and clinical judgment from the doctor and the pharmacist, hospital pharmacist. So we usually need to consider rapid fluctuation levels of renal function, changes in volume status, and the effects of that in renal replacement. So especially in critically ill patients, they might present to the hospital with the symptoms of AKI, but you won't see any increase in creatinine unless like two days later. So that's something to be careful. So we have other types of kidney injuries insults that can occur due to drug-induced nephrotoxicity. And these drugs that usually compromising the circulation can cause renal failure. As I mentioned before, drugs this is NSAIDs, ACE inhibitors, ARBs, and diuretics. And when they're cumulatively used together, they can increase the risk. When they're concomitantly used together, there's a cumulative risk. So because they can cause renal hypoperfusion, pre-renal AKI, which can all at the end lead to end-stage renal failure if the doctors or patients are not careful. So the response to that is usually, if we suspect that patients come with a pre-renal hypotoxicity, we try to respond to the reduced renal flow by which is in diarrhea and vomiting, is by restoring GFR. We use that by prostaglandin mediated vasodilation. So this increases the blood flow to the kidney. But NSAIDs counteract this, so we try to take them off NSAIDs if they're taking any. We give them also renin and angiotensin to mediate vasoconstriction to prevent blood loss. And ACE inhibitor and angiotensin 2 drugs, they can't counteract this, so we also stop them. So if we fail to treat the pre-renal causes, this can lead to ischemia and then later leads to necrosis or acute tubular necrosis. And 80% of the AKIs actually are resulting from pre-renal acute tubular necrosis. So tubular necrosis, this is the latest stage. So if it's not treated, it can lead to intrarenal nephrotoxicity. So tubular necrosis usually occurs due to kidney purification. If kidney purification is not restored, and usually occur due to a combination of two factors. The first one could be, and usually it's a nephrotoxic drug plus other issues such as sepsis. The patient has sepsis or hepatorenal syndrome or rapid hemolysis. The second insult that can occur is interstitial nephritis, and this is usually a hypersensitivity or inflammatory reaction to a drug, which can cause extrarenal symptoms like fever and rash. But the recovery of eGFR usually occurs, but it takes up to a year for it to happen. Another insult that can occur is the acute glomerulonephritis, which is immune-mediated condition triggered by an inflammatory response to the glomeruli. So that's another insult that can occur at intravenous drug-induced nephrotoxicity. So post-renal, these usually occur by drug that affects the renal tube obstruction, like crystal urea. So cytotoxic drugs causing deposition of urate crystals in the tubules. These are drugs that, for example, given for gout, they can cause crystal urea like allopurinol. Clot formation, so any anticoagulant drugs can also cause obstructive nephropathy. Antimuscarinic drugs can exacerbate that issue, so we try to avoid them if patients have renal issue plus any of these, taking any of the drugs that can cause any of these. So this is the list of all the drugs that affect different.
Do you memorize?
You have to memorize all of that for the exam. So you have drugs that can cause acute tubular necrosis, acute interstitial, pre-renal. The most common ones are like antibiotics like aminoglycoside, cyclovir, lithium methotrexate, NSAIDs, allopurinol, for example, aminoglycoside, immunosuppressant drugs, gold treatment, loop diuretics. So these are all the drugs, but you don't have to memorize them. It's just for to know that there's quite a few. Well, it's for common. information. Are you here for knowledge or passing
No,
exams?
for knowledge. we're not asking.
That's it. But for passing exams, what you need to know?
Doctor, serious question on the past, the previous slide. Doesn't this mean that every drug that exists damages the kidney?
Every drug exists what? Sorry?
It damages the kidney, right?
No, but these, well, every drug has its negative sides, but the thing is, I think, don't quote me on it, I'm not quite sure, but I think there's about 300 drugs that excreted by the kidney and can cause nephrotoxicity. So, and more drugs are coming out, so I'm not sure. So it's not many. Most drugs are usually safe, but these are the drugs, and usually they only an issue if the patients have other issues like renal impairment that have cause an issue. But acute injury acute kidney injury does occur regardless of the person's age or anything. Especially, for example, if patients are taking lots of ibuprofen, it's not good. So it can eventually lead to that. So, but I can't say that all drug causes kidney failure. Okay, so usually we looking at the most common ones, which are the drugs that cause AKI and should be immediately stopped. We usually call them DAM drugs. DAM, which stands for diuretic, ACE, ARBs, metformin, and NSAIDs. So these are the most common ones that you should know about. Okay, so to summarize, so you need to, when it comes to dosing, you need to understand that renal function is always reduced in patients who are 65 plus. So we usually assume that they have chronic kidney disease. When it's a single dose, we don't have to do any dosing adjustment. We just leave the dose as it is if it's given once. Toxicity is usually a problem with drugs that are renally, which has high renal clearance and narrow therapeutic index. But most drugs are safe with broad spectrum therapeutic index and liver metabolism. So we usually refer to reference sources or ask for advice if unsure. As I mentioned, we monitor plasma concentration where possible. So although we give the dose and we adjust the dose, but we always have to monitor to make sure that there's no adverse reaction occurs. We avoid nephrotoxic drugs in pre-existing renal impairment where possible. So if we can give alternative drugs, we can do so.
Who do you ask? Do we ask the pharmacist?
Yeah, you ask the pharmacist because this is not your role. So usually, the thing is, yes, I'm giving this lecture. Okay, it's life happens. But you need to understand that dosing is not your role. Your role is to identify patients who are susceptible to have AKI, patients who have CKD, monitor the drugs, understand that there are drugs that can cause AKI, CKD. So you need to identify and understand those nephrotoxic drugs before you go into clinic. So we review nephrotoxic drugs in patients at risk of AKI. So if patients are coming with diarrhea and vomiting, we check if they're taking any nephrotoxic drugs. We are cautioned with drugs likely to increase potassium, cause fluid retention like NSAIDs, corticosteroids, high sodium contents or antacids, or high dose of antibiotics. But the difference between AKI and CKD is AKI, as I said, is temporary. So we usually stop the drugs for some time, and then we put the patients back into the drugs when we think that the risk is no longer exists. Okay, so this is an example. Very cool.
Mr. SL, 93 years old, admitted to the hospital with gout, background of chronic kidney disease, serum creatinine is 140, creatinine clearance is 32 per minute, ibuprofen and codeine started on admission. 3 days later, serum creatinine was 274 and the clearance is 16 per minute. Developed severe drowsiness and respiratory depression.
Ibuprofen is nephrotoxic.
Kidney injury.
Because of what? The depression.
Okay, so you think both of them or one?
Both.
So both are causing what?
NSAID causes the
Incidence.
acute kidney injury, and which increased the concentration of codeine. Codeine causes the respiratory.
Yeah, so it's a AKI insult to the kidney. So I got that. What should we give him then?
Naloxone.
Naloxone.
It was too late. Okay, so we give naloxone to counteract the effects of codeine toxicity. We give them for two to 3 days, and then the patients recover. We discharge them once we think that the creatinine clearance has been reduced to a normal level. And I think then this is back to the doctor with whether he would want to put him back on ibuprofen codeine or maybe just ibuprofen. But usually they would stop this for some time before putting him back on any pain management or try alternative drugs if they could be safe. So these are my references. The only book that I would recommend if you go to clinical and go for clinical rotation is the renal drug handbook.
Doctor, can the pharmacist say that drugs not be prescribed even though the doctor is ordering that drug?
What do you mean?
Can the pharmacist refuse giving the drug to the patient?
Yeah, if they think that the drug is not safe for the patient, yes, they can. That's the role of the pharmacist, because usually doctors, they're not aware of like most of how the drug works and their side effects.
I agree.
And it's normal. It's because as a doctor, all you need to know about is you need to be aware of the drug that can lead to death or issues that can lead you to prison. So you need to stay away from that. But usually, all drugs should be reviewed by the pharmacist, and he has the right to say no, I won't give this drug
The
because
PharmD pharmacist, is that correct?
yeah.
PharmD specialist.
Yeah, but usually hospital pharmacists, I don't know how it works in Saudi Arabia, but in the UK we have like patients usually, pharmacists, they usually specialize. So you have a hospital pharmacist specialized in renal only, or hospital pharmacy specialized in, different types of things. So it's a training that you have to do before you can. But community pharmacists, like pharmacists who work in the like pharmacy, they have the knowledge as well, but probably they're not aware of what other drugs that patients are taking, so they can't make that clinical judgment. So it's usually the hospital pharmacist, because he's aware of all the drugs that the patients take. They can make that decision. Okay, thank you so much.
Thank you, doctor.